Good morning, good evening, good afternoon, good day, everybody. Welcome to our event. Today's event is the vaccination needs of special risk groups, and we have for you today a roundtable summit with some amazing guests who will share with us their wisdom and their expertise. For those of you who don't know me, my name is Catherine Duggan. I'm the Chief Executive Officer of the International Pharmaceutical Federation. It's my huge pleasure to be with you today and to moderate this event. We at FIP try to do as much as possible in partnership with those other organisations with similar interest. So we are super excited to be running this event today with our great partners and friends in vaccination. I have some announcements for you. Before I start on the slide, the webinar is able to be interpreted directly live into French. Just click your interpretation button at the bottom of your screen. In addition, we have Spanish subtitles available for those who need it, and one of the team has put the details in the chat box. Additionally, the webinar is being recorded and live streamed, and those of you who would like to watch it again or would like to share it with their colleagues can do. The recording will be available on our website, events.fip.org. We'd love you to ask questions throughout, and I'll do my best as moderator to weave those questions into the panel discussion a little bit later. You're able to provide feedback to us at our website, our email address, webinars@fip.org. And of course, if eligible, to become a member of FIP and take part in all of our great work. Thanks so much. So we have an amazing panel with us today. I'm delighted, as I mentioned, to be the moderator. I will do the bios and introductions a little bit later as we get to the summit itself, but we have Sean, Howard, Ruben from the FIP team, Pat, Jane and Irina, and Jean-Luc is unable to be with us today due to flight problems, which is now the new normal for all of us as we try and embed travel into our busy lives. So we're looking forward to getting their expertise. The programme for the time that you are spending with us, a little bit of an introduction from me. I will then hand over to my team member, Ruben, who will walk us through the resources we have at FIP on vaccination of special risk groups. And then we have a great panel discussion, including as well questions from yourselves. If you have those, just pop them in and the team will keep me alerted to that. As I mentioned, Jean-Luc can't make it with us today due to some travel problems, but we have representation from the International Primary Care Respiratory Group with Sean, through the International Diabetes Federation, through Irina, International Federation on Aging, through Jane, the World Professions Alliance, my colleague Howard, and the Royal College of Obstetricians and Gynecologists in the UK, Pat. We'll then do some closing remarks and finish the event on time. So today, the learning objectives are to become familiar with the resources we have at FIP on vaccination for special risk groups, to understand the specific vaccination needs of several special risk population groups that have really come to the forefront as we have lived with COVID for nearly 3 years now. We'll be discussing the role of pharmacists in promoting vaccination uptake among these different special risk groups and getting insights from our audience today and our panel about what they would like to challenge us with and the opportunities they see for pharmacy. I'd also like to say, colleagues, we have our commitment to vaccine hesitancy available now in English, French, Spanish and Portuguese. So of course we want to work in collaboration with many of our partner organisations that are here today, but also with many others. But it's important for FIP to make a real commitment for our profession globally. And this commitment does that. Having it translated makes it more accessible. And then, of course, the endorsements by our different partners. We're so excited that with the commitment on vaccine hesitancy from FIP, we have endorsement by 20 civil society organisations listed here. And there's a QR code here that you can access and see the commitment. It's really important that we endorse each other's work where at all possible, so that we can be showcasing collaborations and joint commitments, but also really highlighting where our different professions and groups are taking it forward as well. So our special thanks from FIP to all of our collaborators in this regard. So to our next item on the agenda, I really am delighted to welcome my colleague, Ruben. Ruben is the FIP Practice Development and Transformation Projects Coordinator. He's a pharmacist from Portugal, celebrating the World Cup result from last night, with a master's degree in exercise and health from the Faculty of Human Kinetics in Lisbon. Ruben is currently enrolled in a PhD program, as well as working with FIP. The program focuses on the promotion of physical activity through pharmacies and pharmacists, and he's been involved in different associations and educational activities, focusing particularly on the area of public health and pharmacy practice. Ruben is going to present to us the resources we have at FIP on vaccination of specialist groups. Over to you, Ruben. Welcome.
Thank you so much, Catherine, for this nice introduction. So we've been developing these resources in the past year, and we're pleased to launch and have this summit also as a basis to launch these resources that focus on vaccination, but vaccination for the special risk groups. So for the groups of people that are more vulnerable and probably need vaccination more than the general groups. So today we're going to present the different deliverables that we prepared during this year. So we have 4 digital events already delivered, and we have 2 more that will be delivered next year. 4 videos that focus on the 4 different risk groups, and we'll also work to include the other 2 next year. And 1 toolkit that does the overview of the 6 risk groups, as I'll present later. So we would like to thank all the authors, all the reviewers, everyone from the team as well involved in these in developing these resources, because as Catherine said, if we do it together, if we have a group work, it's always better, because we can do more and we can present more. And we also like to thank Sanofi for supporting this project through unrestricted funds. So for the digital events, you can see the banners for the events. We had chronic respiratory diseases in June, cardiovascular diseases in July, older adults in September, and diabetes on the World Diabetes Day in November. So you can access the QR code on the screen, and you can watch the recordings of all these events, and you can share as well. So as I was saying in this slide, we delivered already the 4 events on the different risk groups. Chronic respiratory disease in June, cardiovasculars in July, older adults in September, and diabetes on World Diabetes Day in November. And we have 2 more events for 2023, healthcare professionals and healthcare workers, and pregnant individuals. So you can see all the resources on the QR code that is presented on the screen. Moving forward, we have also 4 of the 6 videos already delivered. So we would like to thank for the chronic respiratory conditions, Emma Paulino, for the cardiovascular disease, Francisco Javier Jimenez, for the other elders, Jean-Pierre Michel, and for diabetes, Marco Guber. So thank you very much for all those that participated. These are short videos, between 2 and 3 minutes, that summarize the main messages regarding vaccination for these specific conditions. And you can also access them, and you can view them on your devices. As an example, I'll share now one of the videos.
Hello, my name is Emma Paulino and I am a community pharmacist from Portugal, president of the National Pharmacy Association and a board member of the International Primary Care Respiratory Group. Community pharmacies are a gateway to care and as such assume their responsibility in implementing interventions that are people-centered whilst making better use of healthcare resources available. One of the most cost-effective interventions in healthcare is vaccination. And we know that vaccination is particularly important in more vulnerable populations at risk for complications, as is the case for people with chronic respiratory conditions. International recommendations for immunization in people with chronic respiratory conditions include the flu vaccine every year to protect against seasonal flu, pneumococcal vaccines to protect against serious pneumococcal diseases, also the COVID-19 vaccine with a frequency yet to be determined, the Tdap vaccine to protect against tetanus, diphtheria and pertussis or whooping cough when the person was not vaccinated in adolescence, and also the zoster vaccine to protect against shingles when the person is 50 years or older. Vaccines can positively impact health, cognitive development and productivity. We have healthier lives, less severe forms of disease, fewer limitations in terms of family and social interactions, and a better functional ability. Another aspect to have in mind is that vaccines have a broad impact on health, extending beyond the vaccinated individual. And, as mentioned before, vaccines are not only cost-effective, but also cost-saving. Pharmacists can improve the vaccination rate among people with COPD and asthma by recognizing the factors that influence the decision by acting as counselors. And they can also promote the administration of vaccines in the pharmacy itself as a service. Opportunities for improvement include additional training of the pharmacist and other pharmacy staff, raising awareness of the pharmacist's contribution, ensuring remuneration systems are in place for pharmaceutical interventions, integrating health information technologies for seamless transfer of information, and promote increased physician-pharmacist collaboration. Thank you very much for your attention.
So this video is one of the videos that is available on our FIP website and YouTube channel, so you can go there, check them, and also share with your colleagues. The last resource that we wanted to present today is a toolkit. So it's a toolkit for pharmacists that focus on the vaccination for special risk groups, of course, covering the 6 areas that we already mentioned that you can see on the screen. And again, you have a QR code that you can follow, and you can visit the publication in further detail. So the toolkit has different sections, of course, has an introduction that has a quite big summary table and figure that you can see on the right side for the main recommended vaccines that you should have in mind if you're a pharmacist and someone walks into your pharmacy, for example, which vaccine should you have in your head, and think, okay, if this person has a chronic respiratory condition, then which vaccine should I reminded that person of, and so on for the different groups. So this is the first block with the introduction. And then we have 6 chapters, so one for each risk group, that has short explanation of what makes the group vulnerable, or the importance for the vaccination, the recommended vaccines for the specific groups with some studies when available on the different vaccines, and then key messages for pharmacists and also additional information for patients, as you can see below, with some links and external resources, because some of the things are already out there. We just need to link to our also resources. And you can see, for example, this blue box with the white font. These are key messages that are highlighted through the toolkit. And then, for example, you have also on the right side the main recommended vaccines in a simple figure, so you can also have it in mind, or you can print and you can put on the wall, so you know which vaccines to be thinking when you encounter people from these different risk groups. And lastly, we have all of these resources and more on the prevention microsite. So it's a website that has different tabs, and one of them is focusing on vaccination. And you can find a lot of the work on vaccination that FIP has been developing in the last years. And there are many publications, events that you can follow on the prevention.fip.org/vaccination, or just following the QR code again. I think that was it. Thank you so much. Apologies for the technical cut, and CD, back to you.
No worries, Ruben. This does happen, as we well know. And thank you so much for that presentation and for also showing where people can access the resources, and also just send us notes if there are things that we've missed or things that we can build into our plans for next year. Wonderful. Thanks, Ruben. So we'll move the slides on then. We're now going to move into our panel discussion area. I'm going to take a few minutes, colleagues, to walk you through some of the biographies of our different colleagues who are joining us at the panel today. Firstly, it's Sian. Sian Williams is an accomplished public health manager with a large experience working to achieve large-scale change that provides value for the individual, the health system, and society. In her experience, there is significant scope to improve value in respiratory care if we collectively engage all parts of the system in all geographies and apply the best evidence about clinical and patient behaviour change. Welcome, Sian. I'm so excited to have you on board. Next, I have the pleasure to introduce Irina. Irina Vlasenko is a member of the European Medicines Agency Working Party with patients and consumers. She's been in that position since 2019. She's also a member of the representative PCWP of the EMA, of the steering group of European Networks of Centres for Pharmacoepidemiology and Pharmacovigilance since 2020. Further, Irina is the responsible scientific editor of the Pharmaceutical Journal in Ukraine, and she's an international expert in diabetes. She's taken part in the development of regulatory documents, medical standards on national and international levels. She's participated in many meetings with governments and other key stakeholders and attended many international congresses. I believe Irina is actually at an international congress as she multitasks with us today. And she spends a great deal of her time with a view to raising awareness of diabetes and affecting policy changes. Next on our panel today is Jane Barrett. Huge pleasure, Jane, to introduce you. She has a PhD and is the Secretary General of the International Federation on Aging, the IFA. It is an international non-governmental organisation with general consultative status with the United Nations and its agencies, including formal relationships with WHO. Representing over 75 million older people through the membership of IFA, Jane has direct responsibility for the corporation's operational performance, quality and strategic implementation, and business development. These activities include leadership at the United Nations Economic and Social Council in New York, Geneva, Vienna, and the WHO. Jane is a Winston Churchill Fellow and recipient of the Queen Elizabeth II Diamond Jubilee Medal in Canada in recognition of her amazing commitment and passion to enhance the understanding of issues related to ageing and engaging in dialogue with governments and the private sector to improve the quality of life of older people. We're delighted to have you on board today, Jane. Next is Howard Catton. Howard was appointed to the Chief Executive Officer of the International Council of Nurses in February 2019. He's committed to ensure that ICN effectively represents nursing worldwide, advances the nursing profession, promotes the well-being of nurses, and advocates for health in all policies. Howard firmly believes that all nurses should be at the heart of health policy decision-making and leading healthcare systems and delivery. Throughout his career, Howard has worked and written extensively on issues relating to the nursing and healthcare workforce, and he has co-chaired the first ever State of the World's Nursing Report. He has led ICN's work to respond to and support nurses globally during the pandemic and learning from the pandemic, and has been at the forefront of advocating for the protection and investment in the nursing profession. And Howard, through ICN and our other colleagues on the World Health Professions Alliance, is a very close collaborator with FIP. Next on my panel's list was set to be Mary Ann Lumsden, but unfortunately she's not able to be present today due to unforeseen circumstances. We'll cover this area of pregnant individuals in a separate event next year, but we are delighted to welcome Professor Pat O'Brien, who is a consultant in obstetrics and gynecology at University College London Hospitals, UCLH, and is Vice President for membership of the Royal College of Obstetricians and Gynecologists. He's President-elect of Obstetrics and Gynecology at the Royal Society of Medicine. And at UCLH, he has spent time as Divisional Clinical Director for Women's Health and Governance Lead. An RCOG Council member since 2014, Pat has sat on a wide range of committees and working parties at the RCOG and Department of Health in England. He's a media spokesman for the RCOG and has been chair of the international section of the Institute for Women's Health in London, as well as chair for the Clinical Research Hubs Network portfolio board of the hospital itself. Until recently, he was chair of the medical advisory committees at the Portland Hospital and chair of the Women's Health Division of HCA in the UK. He's a patron of the charity Safe Hands for Mothers, which works to promote women's health in low-income countries. Pat qualified as a doctor in Ireland, but his postgraduate training in obstetrics and gynecology has been in London. As you've seen as well, much of his leadership has been based in London with international profile. Pat, we are so delighted to have you here today. Thank you so much for supporting us today and stepping in. Absolutely fabulous to have you. I mentioned at the very beginning, colleagues, that we want to engage with you as much as possible. So please use the Q&A answer box. And I'm going to pose some questions and then I'll ask my team to remind us if we have got any particular questions coming out in the Q&A box as I focus on our speakers. So starting, as we mean to go on, I'm going to ask the same question of all of you, and that will really set the ball rolling, so to speak. So each of you, and I'm going to start with Howard. Howard, we're here today to discuss specific vaccination needs and the benefits of vaccinations for different at-risk population groups. From your perspective, how would you describe the current global uptake of the recommended vaccines by the group you represent?
Catherine, very many thanks. Good to be with everybody. And I know that I've sort of got two hats here. I'm representing the World Health Professions Alliance. For people who don't know, that's the federation, the collaboration between FIP, the ICN, WMA, the dentists, and world therapists, physiotherapists as well. It's about 41 million health professionals that we represent. So, Catherine, I just want to say something about vaccination of healthcare professionals during the course of the pandemic, because all of our organisations and associations were extremely concerned about the snail's pace with which healthcare workers, despite the commitments to prioritise them, were indeed receiving vaccines during the pandemic. Some of the inequity, some of the gross inequity we saw around the world in terms of the pace of vaccinations, issues to do with stockpiling and the frustration in terms of just getting supply equitably distributed. That led, unsurprisingly, to very high infection rates amongst healthcare workers. And we did work with the World Health Organization, which put the number of healthcare workers who we believe died as a result of contracting COVID at around about 150,000. I actually think that's a conservative estimate. I looked carefully, Catherine, in preparation for this, at the latest published data that we have in terms of vaccination, COVID vaccination of healthcare workers. Around the world, about 8 out of 10 have been fully vaccinated. That's not with the booster, but we still see this gross inequity. Full vaccination in low-income countries is only at about a third. And then when you break that down even further, there are still about half of healthcare workers and professionals in low-income countries who have not had a single dose. A critical factor here is supply and equity of supply. I know we'll talk about hesitancy issues later on, so I won't get into that now. But for us, that represents a real challenge, a crisis of rights of healthcare workers, and in terms of the impact on them. But as a consequence, it then has a major impact on health services, the continuity of health services, disruption to essential health services as well. And we know that when we're protecting healthcare professionals and healthcare workers, we are also protecting our health systems. One other point, just by way of introduction in terms of the health professions, which I think is important to flag here in terms of their experience, we saw a very direct line from anti-vax campaigns, from the hoaxers and the soothsayers, through to abuse and violence against healthcare workers and professionals right the way around the world. That included people coming off shift subject to verbal abuse, that the whole thing was a hoax and it didn't exist, even though they'd been working with people critically in intensive care units, through to physical attacks. There's a nurse I was in contact with who was punched by the husband of somebody that she had vaccinated. So this is also a key critical issue in terms of ensuring accurate information as well. There are issues, Catherine, I won't go into them now, but happy to come back to them. I've talked a lot about the impact of COVID vaccinations in relation to healthcare workers. There are issues about the uptake of vaccinations amongst healthcare workers, flu most particularly, where we need to do better. But as I say, I'll leave it there for now, and then perhaps can come back to some of those issues later on.
Definitely, Howard. I mean, this is multifactorial, and we could almost have the whole event based on health workers around this. Might be something we'd want to follow up next year. You're quite right to separate it into issues of access and also the impact on the health workforce, and therefore the impact on healthcare. And we'll come back to hesitancy a little bit later, Howard. I think this is really, really sobering, colleagues, as we enter in the Northern Hemisphere, quite a tough winter ahead, with all sorts of politics and crises across different countries. We also see the impact of other infections, flu, for example, but also we see some of the impact of microbial infections. And of course, we've got AMR in there as well. So Howard, I'll come back to you to probe a little bit further as we go. Next on my list would be Pat. How do you see this issue in the group you represent? Pregnant women.
Yeah, well, I mean, it's very interesting listening to her there, and it's kind of reflected, but worse, I think, in pregnant women. I mean, understandably, I think pregnant women have a natural antipathy or reluctance to take in anything that might be potentially harmful for their baby, and invariably will prioritize the health of the baby above their own health. So when it comes to something like a new vaccine, for example, a COVID vaccine, then it's hardly surprising that there was a real hesitancy at the start, and particularly because, of course, pregnant women have been excluded from the initial trials of the sort of safety trials and efficacy trials of these vaccines, and therefore at the start we could not, hand on heart, say strongly advise pregnant women to have them, the vaccine, unless they were at high risk of bad COVID. Of course, the advice has changed with time as we've realized that pregnant women are more vulnerable to getting bad COVID infection, and also gradually accumulated more and more safety and efficacy data around these vaccines in pregnancy. But the starting point for most pregnant women is not to take in any medicines unless they absolutely have to, and that's completely understandable. So I have to say, with regard to pregnant women, we really were on the back foot, and we're still fighting an uphill battle, it has to be said. It's hard to get accurate data on uptake, COVID vaccine uptake, but in the UK, it's probably around 60 to 70% of pregnant women at this stage. Although improving, I think, largely because a large proportion of women, of course, now have been vaccinated before they fell pregnant. So they don't have that decision to make about getting vaccinated while they're actually pregnant. I mean, even if we take a step back, for example, to flu vaccines, uptake of flu vaccine among pregnant women right across the world has been notoriously low, and it's probably mainly for the same reason, and also because of the sort of complacency that there is around flu infection in pregnancy in people, I guess, of that relatively young fit age group. So the final point I make is, I say, when it comes to the decision to take any medicine in pregnancy, just as it is in people who are not pregnant, it comes to a weighing up of the pros and cons, the potential risks against the potential benefits. And there's no difference between a COVID vaccine nowadays, I think, weighing up the pros and cons, than there is for many of the other medications that we routinely recommend and prescribe during pregnancy.
That's a great set of comments there, Pat. I think the big issue for us is balancing up the way we communicate with those who are pregnant about it being totally healthy, it's natural, and you are fit if you keep yourself fit, with the balance of taking anything during pregnancy, and then also saying that a medicine that we don't know much about, whether it be a vaccine or let's say an antibiotic or even another medicine, won't be harmful to you. And it's that little triangle of communication where there's a lot of conflict between the three messages there that we need to iron out a little bit. Fascinating insights. I'll come back to you in a while. Next on my list, I'm going to move to Jane. What other specific issues you see in older adults in this area? Jane.
Look, thank you, Catherine, and thank you to FIP. I think first and foremost, the question is, how would you describe the current global uptake? And it's shamefully suboptimal in adults and older adults in every single country of the world. And that was before the pandemic and also after the pandemic. So to even consider optimal coverage targets, they must be universal and consistent across the entire population. And this is not the case. We have targets for influenza, which are different in children to those in adults. So we have to understand what we're really talking about when we describe optimal uptake. I think the other aspect, this phrase of at-risk population groups is very loaded. What do we really mean by that? And what do pharmacists need to understand? Adults usually 60 to 65 are classified as at-risk populations, but that changes from country to country and also within country. And so the national immunisation technical groups, have a responsibility based on epidemiological data to actually, classify those that will, for example, have an enhanced influenza vaccine. I think that then leads us to try and unpack those who are at risk in this population. So clearly with age, there is immunosenescence, but also 1 in 3 adults actually have living with more than one chronic condition. And the prevalence of NCDs, non-communicable diseases, is galloping along. So I just want to close that question by giving you 2 really concerning facts. One is that in a study that IFA has just finished on looking at the composition, transparency and regulatory framework of NITAGs, only 2 countries in 34 countries had an expert in the field of adult vaccination. So when we're talking about life course immunisation and at-risk populations, we need to be very clear that it's represented well in the authorities that are making the recommendation. And the second is even perhaps more alarming. In a study of 19 countries in long-term care facilities, there is little or no evidence of vaccination policy in long-term care facilities, aged care policies, or national immunisation strategies. And so when we're talking about at-risk populations and uptake rates, we actually have to go to the source. NITAG recommendations, epidemiological data, we don't have accurate disaggregated data to base policy on. And of course, we actually don't have the focus on healthy older people and those older people who are frail. So we have a tremendous amount of work to do, but thank you for the question.
I think, Jane, what I'm taking from that is that all the groups across our population should be treated specially, but we need a better word to describe what special means. So that's a really good reflection. And also, you mentioned about the age ranges in different countries. Even as individuals, your difference between being one age to maybe a year or 2 later, you could be in a completely different place of risk or needing some special treatment. So this almost all needs unpicking as we go through what we call at risk and what is special. I think that's a really useful point. I do quite like the fact that when you use terms like that, they can spark further debates. And I think this will really help us drill in a little bit more. I'm going to move to Sian next to describe the experience within those patients with respiratory diseases or with any manner of respiratory problems. Sian.
Thanks, Catherine. Yeah, so just I want to echo quite a lot of the things that people have been said and add in a few more points. So we represent primary care for people with chronic respiratory problems, including asthma and COPD. So firstly, building on Howard's point about healthcare workers. So I absolutely agree, they need protection. They're also role models and potential vectors of transmission. I want to focus on flu, which he said he might want to come back to, because there is significant variation in flu vaccination uptake in healthcare workers pre-COVID and now. And there's good evidence that it reduces healthcare worker absence and lost work days, which everybody's under so much strain at the moment. Everything we can do to protect the system will be, and the individual will be great. For people with asthma and COPD, so as Emma said in the video, for asthma, in addition to COVID, flu vaccination is recommended in all international guidelines. And for COPD, it's flu, pneumococcal vaccination, shingles, and pertussis, diphtheria and tetanus, if people didn't have it in adolescence, as well as COVID. So that's 5 vaccinations that are recommended potentially for people with COPD. And uptake is incredibly variable, but the problem is, we have such mixed ability to diagnose asthma and COPD that it's very hard to know what the uptake is. And it's also very hard to alert people to have the vaccinations because there is variation in diagnostic rates. So we have to improve diagnosis, and also where people are diagnosed, we have to improve coding. So there were big challenges in the UK, which does have reasonable diagnostic rates, because what were people searching for in the code to know who to prioritise and who to bring in? And then that brings a further issue about the communication between pharmacists and general practice about who has access to the codes and to the records. So there are a number of system problems that need to be addressed in terms of communication between pharmacy and general practice, where general practice exists, improving diagnostic rates, thinking always about these two sides, about the healthcare worker and the patient at risk. And I think we're sort of reasonably clear about who's at risk with asthma and COPD. It's everybody. So just got to improve the diagnosis rates first.
See, Sian, I really love that concept, and who's at risk of, aging, for example, everyone. Yeah, these points are really, really well made. And I do believe that very often we describe things in our populations as though they are groups that we aren't part of, whereas prevention agenda is about keeping everybody healthy and safe, whether they're health professionals, whether they're pregnant, or whether they're living with multiple morbidities, and or, as we all are, aging. Thanks so much, Sian. We'll come back to those points as well with the questions. Irina, to you, from a diabetes perspective, what are you seeing?
Thank you. First of all, thank you very much that we pay attention for this problem. That is also a specific group. It's very important. We must make exactly what they need and be sure that our advice is right. From a diabetes perspective, patients with diabetes are at increased risk on several influence disease. And type 1 diabetes, for example, which related with metabolism disease, also increase risk in infection. And why this influenza vaccination for those patients is therefore recommended by the World Health Organization and several national immunizations. And but unfortunately, adherence to vaccination program for our group is very low. For example, 50, 18, 17%, according to some studies. And we must be more active in this. Why IDF, International Diabetes Federation, joined to this commitment on vaccine hesitancy. It's a great job, and we can use this material for our patient and our doctor and pharmacist. And it's a lot of barrier for provide this information. First of all, I think it's lack awareness, and not only people with diabetes, but also healthcare provider, endocrinologist, and also a family doctor who now are responsible for type 2 diabetes. And this is routine vaccination must be done, but not focus on this, only focus maybe not treatment of diabetes, but not focus how very important vaccination in this group. Yes, we have some information, some study which shows that after the vaccination could be increase blood glucose level, but this is maximum 1-2 days and go back to normal situation. This is not barrier, but also need provide information, and I'm very happy that you make document which concrete show how it's do and why this is very important. And and also I think that our patient who must self-management themselves is very quite educated, and if we deliver this information, they will follow. But they also for diabetes people very important advised doctor, and we have, as I recognize, we have very large communication with doctor and pharmacist. Sometimes doctor, I work in this, a lot of doctor, sometimes they like reject us, this like them area, but I think it's very important our role in this increase vaccination in specific group and also in general population.
Thanks so much, Irina. I think this will really, really come to light as we go through the next question, which is for the whole panelists as well. This is a very, very insightful point. I just got a couple of things I mentioned, colleagues. Our interpreter is finding it a little bit hard because many of us as native English speakers are speaking fast. My hand is up, I am guilty. But also, colleagues, I'm going to move us on to the next point now. I've got some of the ideas as well when we think about special risk groups, that we're really thinking about the groups themselves that need some special interest, as opposed to they themselves regard themselves as special. But we'll come to that as we go through. I'm going to go round in the same order again. Howard, for you, in some countries and for some vaccines, uptake rates are below the recommended targets. You mentioned this in terms of nurses, but also all healthcare professionals. What do you think are the main barriers for increasing vaccine uptake for the recommended vaccines over the life course? Obviously, you can pick patient groups if you'd like, but particularly with an interest to nurses and healthcare professionals.
So I think, firstly, there is absolutely a fundamental issue about access, convenience, and no cost, no charges as well. And for parents who understandably want to be with kids if they're having their vaccines, they don't want to have to take time off work. So those fundamentals around access, around convenience, and around no charge, I think are absolutely critical. We, like many others, have been hugely concerned by the drop-off in kids vaccinations in terms of DTP and MMR as a result of the pandemic. That again points us to issues with supply chains and lack of access, but also a real challenge with diverse resources often having been diverted to other parts of the health system. And I think there are some real issues around catch-up campaigns and urgency around catch-up campaigns for those groups as well. If we just touch on the hesitancy issue as well, because I think it's a barrier. The health professions are in an incredibly potentially influential position because of the trust that they have with those people who they care for, that they look after. They're always highly rated in polls of most trusted people. And I think those hesitancy questions are firstly about recognizing people will have legitimate questions. You know, we're not going to stigmatize them or be judgmental about the questions that people have. They need time, and they need the right information, and they need to talk that through and not feel as though they're being overly cajoled into making a decision. Nurses and other healthcare professionals have huge reach into all of the groups that we're talking about over the life course. And I think there is an issue for all of us to make every contact count, to take every intervention to talk about whether people, whichever stage of life they happen to be, whether they are up to date with vaccines. And I think there is a responsibility from the health professions to be very clear about the responsibilities of the groups they represent. ICN earlier this year, we put out a very clear position from our board that we believe it's a professional responsibility for nurses to be vaccinated. Of course, if there is no medical contraindication to that. I think it's incredibly helpful where employers make it clear in their policies as well what their expectations are, but to do this in a way where we create a positive narrative around prevention, shifting it from disease to well-being to health, but also perhaps for people to recognize that a vaccination could be the easiest thing you could do to save another person's life. I think Catherine may have dropped off.
Yeah.
Apologies, Howard. I just had a Wi-Fi issue myself. Okay. I was going to mention that I think some of these issues have really become loud and clear in the pandemic. That prior to that, as a healthcare professional, you may have held the view that everybody should be vaccinated. And that if you take that view, which may still be your belief, you can alienate those that have got questions. Of course, there are some people who won't and don't believe in them, and they won't change. But then you've got the mixture, the middle group, I would call them, who could be influenced if you take time to really explain and to articulate some of the issues. So that's a lesson for all of us, I think. Really, really useful. And apologies, colleagues, I just went off the camera to see if I could reboot. I'm fully Wi-Fi'd up now. I'm going to move to Pat O'Brien. And Pat, we've got to just take it a little bit slower for the interpreter. What would you say to the same question?
So when it comes to sort of uptake and hesitancy in vaccinations in pregnant women, what do people say to us? Well, pregnant women will say to me, well, at the start, you were telling us, you were advising us not to have the vaccine. You told us it was completely unsafe. And now you're recommending strongly that we have the vaccine. How can we possibly trust you anymore? And that's not true. What is true is that at the start, yes, that was our recommendation, as I said before, based on the lack of evidence about COVID infection in pregnancy and safety of COVID vaccination. And gradually, as I said, as those two streams of knowledge accumulated, our advice changed. Now, in fact, that is the process that we go through with every single medication and indeed intervention in pregnancy. It's just that usually when it comes to medications in pregnancy, that whole process takes 10 years or 15 years or longer. And what's happened with regard to COVID vaccination in particular is that whole process has been compressed into 18 months or 2 years, so that it's become very obvious to people out there that there's been a transition. It's just that it's happened more quickly than usual. So people say, okay, but how can you tell me that this is safe for my baby long term? And I say, well, first of all, we have a huge amount of safety data now on the safety of these vaccines and efficacy in pregnancy. We published a paper in Nature Communications a couple of months ago that looked at a whole range of pregnancy outcomes like miscarriage, stillbirth, poor growth of the baby, preeclampsia, etc., and showed that there is no difference, no increase in any of these adverse pregnancy outcomes in women who've had the vaccine, and indeed show that there was a 15% reduction in the risk of stillbirth in women who'd had the COVID vaccine in pregnancy. So pregnant women say, okay, that's fine. So what about long-term? These babies have not been followed up long-term. How do I know that in a year or 2 years or 3 years, my baby will not show any signs of harm as a result of this vaccine? I think that's a fair question. You could say that about just about any medication in pregnancy. But first of all, from sort of scientific first principles, there is no reason to expect any long-term problems. Secondly, we now have some studies emerging, a follow-up of these babies to 6 months and a year of age, and no sign of any issues. And perhaps most importantly is to say that neither have there been any long-term studies of the babies of women who've had COVID infection during pregnancy. And in fact, a study from the United States published in JAMA a couple of months ago looked at neurodevelopmental outcomes of babies born to mothers who had COVID during pregnancy, and showed that there is an increase at up to 12 months of age, an increase, a small increase in adverse neurodevelopmental outcomes of babies who were born to mothers who had COVID during pregnancy. So I think it's a fair point to say we don't have very long-term outcome data for these babies, but it's very, very unlikely that there will be a problem. There's no sign of a problem at this point. And you also have to bear in mind the chance that COVID infection during pregnancy might carry some harmful effects to the baby.
Very well, points very well made there, Pat. My view on this is, as you say, that we've just been living a very, very compressed life. And normally you'd be in a situation where you could watch the evidence emerge and then face that for your personal situation. Whereas actually COVID just surrounded all of us and we all had to respond and react. I had a very interesting challenge the other day from a non-health professional colleague who said, well, now we understand that they weren't necessarily quite as safe as they thought they were. And I said, well, that's not quite the issue. We didn't have the evidence. And in addition, we did have the evidence of what would be the impact of having COVID. And that's the alternative, wasn't it, at that point? I think now that's a little bit less of an issue if you have some immunity. Very, very interesting. And I'm coming to Jane's point. I'm coming to Jane next anyway, but Jane, this shows you that some of the special consideration we give these at-risk groups is the same for all. It's about understanding what the issues are in that population at the time. So coming to you, Jane, what would be your view around this issue in an aging population?
Look, Catherine, you're quite right. Some of the issues are the same. And that's why when we talk about life course, we need to take into all the considerations. But the question started off with recommended targets. And I want to make the point again that we don't have targets for older populations. So we need to actually, that's the first thing. What are the recommended targets? And they must go beyond influenza, right? We've got WHO targets for influenza, but we don't have them for pneumococcal. We don't have them for pertussis. And so we really have to, at the same time as we're unpacking the barriers, we've actually also got to hold the policymakers to account about targets. You know, one of the questions about barriers, I think about barriers in terms of structural barriers and modifiable barriers. They're not mutually exclusive, but let me explain. We've already talked about health promotion and prevention, but we know the percentage of GDP in OECD countries around investing in prevention and promotion is minuscule, like it's less than 5%. But then if we look at prevention and promotion, prevention of vaccine-preventable diseases and promotion of vaccines, you know, it's even more more minuscule. So that is a structural reform. So in a perfect world, we would have a healthcare system reorientated to health promotion and prevention. So that's a big system change that we need to advocate for. If we're thinking about barriers that stop or prevent an older person, we know them very, very clearly. One of them is cost. So cost to be vaccinated against pneumonia, it's a very high cost. My shingles vaccine cost me over $200 Canadian. Now, many older people cannot afford that. So cost is a big thing. And that then prevents equity. It prevents it, it stops it, because we don't have a universal system. But there's modifiable factors such as complicated access. So in your field, Catherine, we know that pharmacists is a go-to, but in some countries, they can vaccinate against X, but they cannot vaccinate against Y. Why is this the case? So poor access or complicated pathways. If an older person has to make an appointment for the doctor, go there, have the conversation, get the script for the vaccine, go to the pharmacist, get that filled, then make another appointment to go back to the doctor, they're not going to do it. So cost, poor and complicated access, misinformation. We still have a very low level of awareness. And I agree, healthcare professionals across the board are trusted. However, some are not. Our studies in France and Germany, told us in 1,000 older people, sometimes they weren't so sure about the information. So we need to be consistent with the information. And of course, in some countries, we have insufficient qualified people to vaccinate. So once again, it's multifactorial and it's very situational specific. We cannot use a cookie cutter approach. We've actually got to do an audit on the ground level. And that's part of the IFA's work in the Adult Vaccination Advocacy Toolkit.
See, this is the great point, Jane, about being able to cross collaborate as well, and where the different agencies we have on the call today and the other collaborators can take a lead in a certain area, and then we all support that and push that forward. And I think, Howard, you and I need to take forward some of these cross-professional issues, which I'll come to in the next questions. I think, Jane, you're quite right. We've got to look at the structural problems. Some of those we might be able to solve, but some of those might just be so embedded, we need to ride above them and learn from countries where there might not be such rigid structures in place and how they're doing things. Lots of lessons here. Very, very excited about it. Thank you so much, Jane. I'm going to move us to Sian now. The same question to you. I'm seeing themes coming out now, and you won't be held to ransom if yourself and Irina say, we agree, because these are very cross-cutting.
Absolutely, access, convenience, cost. I think in terms of the structural things, I think one of the issues is that a lot of healthcare policies begun to split communicable disease from non-communicable disease. And, there are separate units within the WHO, and it often gets divided. And yet, of course, these issues cross. So we're talking here about flu vaccination, flu vaccination, for example, pneumococcal vaccination for people with a chronic disease, so with asthma and COPD. So this is about flare-ups, preventing flare-ups with people with a chronic disease. And so I guess there's a question of who's in charge and whose responsibility is to come up with policy. I think that there's also a prioritization question. So just it's a global level, well, hang on a minute, where do we put our attention? You could argue that pneumonia is the leading cause of morbidity and mortality across the board, not age specific. I mean, it's childhood pneumonia as well as adults and older adults. Would that be a priority? But of course, where we are now with COVID and so on makes that challenging. In terms of specifics, to people with asthma and COPD, or people with COPD regarding COVID and their whole range of vaccines, what some of the access problems are that they can't do these repeated visits. They're fearful of going out. So we need to try and simplify the vaccination regime so that they have fewer visits, so that they have more than one jab on the same day. That requires people to understand that is that okay? People are fearful about having more than one jab on the same day. There are also fears of drug interactions. So when you've got people on multiple drugs long term, then they want to understand about any potential interactions, which brings me to the theme of knowledge. So Pat mentioned this as well, knowledge changes over time. We now know, for example, that people with asthma definitely are more at risk of hospitalization with COVID. To begin with, we weren't sure because we weren't seeing people attending, so that's, this is Lancet Respiratory Medicine 22. So we have to explain to both professionals, so they're up to speed with it, and to the public how knowledge changes and what impact that has on decisions that get made. And that's a really tricky thing to communicate. So those are the main things. One, about this divide between communicable and non-communicable doesn't necessarily help us in this field. We've got multiple injections needed by people. How do you just manage that very practically? And then how do you communicate changes in knowledge over time in a simple way that everybody can absorb, given how much else they're trying to absorb at the moment?
That's super, Sian. And you mix that with some of the practical ways that Jane mentioned about just streamlining the whole process, so that you may have somebody able to have a one-stop approach to getting one or many vaccines. And there's a lot of helpful information there, Sian. Thank you so much. And I think I can see a lot of this transcends whether you're a health professional in this area, whether you are an aging person, whether you're pregnant, whether you have respiratory disease. Irina, what about your experiences with diabetes?
Thank you. I also want to add about how we can destroy this barrier. This is also communication. We must prepare some way which deliver a very simple. And I find that clinicians vaccine safety resource guide optimizing prevention of vaccine-preventable disease across the lifespan. And this is underlined that we provide a 5-step strategy to work with vaccine resistance patients, establish empathy and credibility, briefly address specific concern, if any, pivot to disease risk, convenient vaccine effectiveness, and guide a strong and personalized recommendation. And another side, I only thinking about practical thing. Look on our pharmacists. They're busy. They stay in our pharmacy, and they must have motivation for do this task. From my side, it's very important. It must be national program, something like that, and then involve not only doctor for delivery this information for patient, must educated, but also motivated. Includes pharmacists like in one system for deliver this information, for increase vaccination. And I also think that it's a lot of barrier, but it's possible destroy this and get this good percent vaccinated people. What we saw in with COVID vaccination, we are and some people very happy be in first line, like in Greece, like diabetes. I was in first line. I have risk diabetes, and I was first line, got this vaccine against COVID. But I was more motivated than somebody else was, because deliver information that I have risk and that some people dead, something like that. In awareness, educate healthcare professional, and also motivated them.
Thank you, Irina. I think there's some really valuable pieces there where you should work with your motivated groups to begin with, and actually they then create their own evidence base to be able to communicate with those that may be a bit more hesitant. I'm coming to hesitancy in a second. Sian, I forgot when I was summing up from your point about the separation between NCDs and CDs is just so fake. And, you know, in pharmacy, we love to box things up and put a neat label on it. It is our professional trait. And for this, we have visualized the prevention agenda as a Venn diagram with NCDs. You've got the prevention of the NCD getting worse, but then you've got the prevention agenda that can stop the emergence of such bad NCDs. And I think some visualization of this may be very, very helpful as we move towards sharing these commitments. Sian, I'd welcome your reflections on that. Yeah,
absolutely. Yeah. Thank you. Yeah, will do.
Lovely. time marches on, colleagues. I'm going to focus now with Jane and Howard about hesitancy. I can also weave this into the next question as well. But for both of you, vaccine hesitancy is an important and growing concern. I think it has always been there. Howard, you really well articulated this earlier. It's deserved our attention in the past year as we launched a publication on the topic. So from both of your perspectives, I'll start with Howard and then move to Jane. What role do you think vaccine hesitancy and complacency play in hindering the achievement of higher vaccination rates and the vaccination pathways? You've touched on this already. And actually, Pat, you mentioned about complacency in perhaps populations that view themselves as healthy. What would be just a couple of thoughts, just building on what you've mentioned already? And I'll start with Howard and then go to Jane. And if anyone else has a point to make, we can come to them.
So I talked about the legitimate questions that people have, having a positive, non-judgmental conversation, focusing on prevention. I think that's that's fundamental. But let me, and I will dig into the hesitancy specifically amongst healthcare workers, because I think it's important that we tackle that head on as well, and we don't shy away from it. When I talk to health professionals who may be hesitant, and from some of the studies that I look at, then what I see are some similarities with responses from the general public, people concerned about what the side effects might be from having a vaccine. Often interesting from younger health professionals who just think, look, we're fit, we're young, we're not a high risk group. There are all of those convenient questions about we're busy, we just can't get round to it. And there are also distrust of pharma issues in there for some healthcare professionals as well. And that's what we hear. That's what some of the studies show us. A recent study, Catherine, that I was looking at, this is from the States, was looking at vaccination rates amongst all healthcare professionals, but it then broke it down, and it said, look, this is at the end of 2021, 80% flu vax rate across all healthcare professionals. Doctors, nurses, pharmacists, better at 90%, but then a fall to around 60 to 70% amongst support workers, aides, and assistants. Put all of this together, I think that there is a key education issue that we shouldn't miss for our healthcare professionals as well. They have their legitimate questions. They don't know it all. Let's not assume that they know it all either. And in terms of finding the time and the space, not just within pre-reg programs, but part of CPD is ongoing development to talk to people about vaccines, about dosage, about side effects, about all of those issues. I think is really, really important. And as I said, I think that there is a professional responsibility, and I think that we need to not shy away from that. We took some criticism when we came out and said it from from ICN, people who thought that was a step too far. But I think we need to do it in a in that positive spirit, but also to recognize we are role models. We are role models for lots. So that doesn't mean that we're not subject to the same pressures and demands as other people, and working in very, very, very difficult and busy and challenging systems as well. But if there are significant numbers of nurses, other healthcare professionals who are not getting vaccinated, other people will legitimately point to us and say, well, why should I do as you say when you don't either? But I think there's a big education issue in there as well, Catherine.
There is indeed. Before I go to you, Jane, Howard, there's this real dilemma about how health professionals are viewed. They're either superheroes or they are, not professional. There's the dichotomy there. If we really want to understand why our health professionals aren't being vaccinated, we could really learn a thing or two and then extrapolate that out to the communities and the population, because the health workers are part of those communities. That would give us valuable insight. It also leads to a greater authenticity. If you have somebody who says, well, I had doubts at the very beginning and this is what helped me, that makes you more human in your approach. So I think this is very, very vital. And you are role models as a health professional, but you're also human. And I think that's another thing that perhaps our communities have cottoned on to more than our governments and our policymakers. Perhaps everybody's suffering the different crises together. Jane, your reflection on that. Then I'm just walking everybody through how I'm managing. Pat, I've got a question for you, and then I've got a question for Sian and Irina, and then a final roundup question before we all finish. So Jane, to you. I think you've touched on this brilliantly already, so it's a summary from you. Perfect.
Look, thank you. Look, authorities and perhaps some of us on this webinar are very quick to label older people as hesitant before understanding whether there are social, economic, environmental barriers impacting their decision and or their physical action to be vaccinated. So it's really easy to say, oh, look, they're hesitant. And I think that's wrong. I think we actually have to take a step back. And we've all talked about this today, about education, education of healthcare professionals, education of the community. How much do we really invest in that? Where is the science of public health messages and campaigns? It isn't happening. IFA is doing some work with WHO around a social behavioural adaptation of a toolkit for adults. But we really are very quick to sort of put that stamp. Older people are not a homogeneous group. Guess what? So we actually have to really tailor what we do. I just want to mention a study by Zhang in Hong Kong in 2022. And this was around hesitancy and resistance around older adults in the 5th wave of COVID. Now, what they talked about, what they found, the common reasons for not being vaccinated was ill health of the older person, being isolated, being marginalised, and having less access or no access to the internet and social media. And so their recommendations are what we've been talking about today. Strategies with targeted communications, connections with the community vis-a-vis care workers, as well as pharmacists, with clear, timely information. And this word timely is actually important because we have been deluged with information about, have you had your first vaccine, your second vaccine? Are you up to your 5th vaccine? What vaccine? But think about pre-COVID. Was there such a flurry of conversations about pneumo or pertussis or Tdap? There wasn't. So how do we actually shift the conversation to routine immunisations and really understand whether older people are hesitant or whether there are modifiable factors that we can change in the community? Thanks, Catherine.
I think it's great. I think, as we move our heads out of COVID only, these questions become more and more important. And a real take home for us on the call today and everyone listening in is no one of these special at-risk groups is homogenous. There's no one size fits all, whether you're talking about health professionals, aging populations, diabetes, respiratory, or indeed pregnancy. I'm going to move to Pat now and get you to focus on that. If the other panelists have comments on the next 2 questions that they'd like to capture, just for efficiency, I'm going to get us to focus on that, but you can absolutely add that to the chat box. So Pat, got a question on pharmacy-based vaccination, and it might have been something that you were completely aware of, but maybe something that we are increasing your awareness of today. Jane mentioned earlier that pharmacists can vaccinate in some countries, not in others, but let's just take it as pharmacy-based vaccination is a success and that it's consolidated. Let's imagine that we're at that stage now. What would you recommend to us as a profession would be the strategies that pharmacists can use to promote vaccination for pregnant women in communities that you would see? Also in other settings, perhaps.
So, first of all, in terms of convenience, come back what Jane was saying there, convenience is a major factor. So in this country, in the UK, pregnant women, for example, will be given priority for vaccination for the flu vaccine in local pharmacies. And it's so much more convenient than having to wait till their next hospital appointment, which might be 4 weeks away, etc., etc. So in terms of convenience and increasing uptake in that way, that is fantastic. In terms of pharmacists having the knowledge and the power to educate women so that they're more likely to have these vaccines in the pharmacy setting. I mean, clearly pharmacists are very educated, but also, I mean, organizations like ours, so the Royal College of Obstetricians and Gynecologists and the Royal College of Midwives, we have a COVID vaccination guidance for pregnancy, which is now on version number 16. But we also, on our websites, have information for pregnant women around COVID in pregnancy and COVID vaccination, and a decision aid that helps women who are uncertain about whether to have a vaccine or not, to sort of guide them through the thought process and reach a decision that's right for themselves. So what I would say is that pharmacists having access to these resources and signposting pregnant women that come into them towards these resources, rather than reinventing the wheel themselves, I think might be very helpful and a bit more straightforward, and getting a consistent message and line out there.
That's fantastic, Pat. We couldn't agree with you more. Reinvention of the wheel is just such a duplication, such a waste of efforts, and there's much to be done. And if you've done all that work in 16 drafts or 16 versions, then we'd welcome being able to share that with colleagues. Fabulous. So I'm going to move to Sian and Irina now. And again, everybody else on the panel is very, very welcome to reply as well. Both of you will know that FIP recently launched a publication focusing on co-administration. And both Howard and Jane have mentioned this in different points in the conversations today. Co-administration of COVID-19 and influenza vaccines. We've seen how these two viral diseases are particularly severe in different ways for those living with diabetes and those living with respiratory conditions, or even those developing them. How do you think co-administration of these two vaccines could benefit the group that you represent? And Jane, I'd welcome you just popping something in the box because we heard this from you earlier. So I'm going to start with Sian and then Irina.
Well, I think it's a good idea, and I think a lot of patients do too. So it makes sense. It's one journey, but we need to allay the fears that that's too much medicine in one go. There are practical solutions to that, about different arms and space between which people are using. The other thing is, of course, the processes that I use to remind and call people to the vaccination centre or to the pharmacy, to wherever it might be. So at the moment, COVID systems seem to be operating in many countries separate from things like the annual influenza jab. So people are getting messages from two different sources. So there's something in the background about how you can make sure that call and recall systems are joined up.
So a bit of systems smoothing, as well as the education piece. There's a lot of themes coming out that really can cluster together to make this a very much more optimized approach. Thanks, Sian. What about you, Irina, for patients and the public living with diabetes?
Thank you. It's, to be honest, it's a difficult question for me. I will be maybe multi-wave. I will use this, and also if I find some study which shows that we saved like $90 for one patient if he vaccinated. This is also influence on our healthcare system, financial stability, and I will be not push for to vaccine together. As patient with diabetes, we have. I will be not push this.
So you're saying that in those patient groups, you'd want some more evidence at this point.
Yeah.
Perfect. Absolutely fine.
Especially if you want like together make it like more optimal way. I understand this is much better, much cost effective for healthcare system because use less resource. But anyway, we also must thinking about risk.
Patient benefit, yeah. I think it also showed, it comes to the point, Jane, I remember you mentioning the cookie cutter earlier on. We can't just apply one size fits all to everyone. We have to cater it, but do that in an efficient way. It shouldn't be beyond us to be able to think, we need more evidence in that patient group or in that population group to be certain of the interventions we're doing. Yeah, very good, lovely. We're going to come to the final question now, which for all of our speakers, our panelists today, is what would be your final take-home message, or what would you tell us to be our final take-home message? I'm going to start with Irina. I know, Irina, you might have to leave the panel pretty quickly, but also you've waited to the end of each of my questions. So let's start and move backwards in that regard. So Irina, what is the final take-home message for FIP from you today?
I think awareness, used any chance for speak about this, only maybe even one question from pharmacists, like, do you vaccinated? Do you know about this? It's open question, and maybe some of them listen, not everybody, of course. But anyway, I'm sure that simple intervention will have increased vaccination. And special our role, like pharmacists, where people come to us more, we are more accessible for people, affordable than doctor. This is our super role in healthcare. It's my strong opinion, you know.
I take that from someone inside the profession as well. So use every opportunity to explain. Wonderful.
Yeah.
Thank you so much, Irina. If you have to jump off, I just wanted to make a special thank you to you for your contributions today. If you're able to stay, we'll do the final group. Thank yous.
Thank you so much.
Thanks a million. Thank you, Irina. So Sian, from your perspective, what is your final take-home message for us here at FIP and for the panel and the attendees today?
Thanks. I think it's really about thinking about value, and when we're thinking about high value interventions for chronic respiratory disease, vaccination needs to be there right at the top. And we also need to think about those teachable moments that pharmacists have. So it's 2 points, sorry. It's value, the link is value, it's value of pharmacists, and to grab every teachable moment. Sometimes it won't be about vaccination, it will be about smoking cessation. You know, I don't want us to start going down one track and forgetting all the other things that we already think are important. It might be about inhaler use. So you've got to choose the teachable moment and make the most use of it to get the highest value for everybody.
That's great. I think there's a lot of overlap there with Irina as well. It's the explain and educate. But as you say, Sian, don't just take the vaccine route. Think about the other messaging routes as well. Lovely. Fabulous. Jane, I'm going to come to you next about your single, and don't worry if you've got an A and a B and a C, don't worry, we'll capture it.
You know me too well. I'll be quick. Immunisation is for all ages, and pharmacists must work to be able to administer across life course. I mean, that's efficient, effective, and you're a trusted source. Older people are not all the same, so that booster conversation is critical. Know your modifiable barriers in your community. And it could be as simple as have infographics, images with big print. And pharmacists are trusted sources, but we, you, me, we cannot be complacent in this environment. And it's not only COVID. You know, we must be vigilant to vaccine respiratory preventable diseases now and in the future. Thank you.
Yeah, I think COVID's made the spotlight very bright, but Jane, this is not just about COVID, is it? It's about everything. Use this as an opportunity. Bit of a tidal wave is what I'm hearing, colleagues. Pat, I'm going to come to you next. Your single take-home message for FIP today.
So it's about information, and two things to it really. One is that it is really paramount that we all work together, national, international organizations work together, so that we, number one, don't reinvent the wheel, duplicate work, and number two, produce information that's up to date and accurate and consistent, so that there's no question of anti-vaxxers sort of splitting us and saying we're disagreeing. And to follow on from that, to say it is absolutely paramount that moving forward, pregnant women are not automatically excluded from drug trials and vaccine trials, etc., etc. And that applies not just to pregnant women, but to other higher risk groups like children, etc., etc., who are routinely excluded from early stage trials. They must not be included because COVID has shown that the exclusion of pregnant women from vaccine trials has led to reluctance to have the vaccine, and a lot of suffering to women and babies that could have been prevented if that information was available 18 months earlier.
It could draw us into a wider debate, Pat. I'm thinking for my team to log this, which is clinical trials or drug testing full stop. I've got elderly parents and they would quite happily be part of some trials as well. So it might lead us to think about this in the round. And you're right, if you're excluded at the start, how can we expect people to immediately feel that they're included later on? So this could be a very, very nice. We might be back to discuss this with you. Thanks a million. And thanks also, special thanks to Pat for jumping in today. That has been splendid to have you on board. That voice is really, really valued. Howard, last but by no means least, what would be your one take-home message for us at FIP and indeed for ourselves at the Alliance?
Well, you flipped me to the end, so all the above. Of course, I agree with everything that's been said. But let me throw this one in, because I think it is not just about pharmacists; it's about all of the health professions. And, and I started by saying, we're an alliance of 41 million healthcare professionals. Think about that reach. If you did some simple numbers about how many patient interactions are those 41 million health professionals having today? What does that equate to over the week, over the month, over the year? That reach is the route to increase vaccination rates. Route rates was what I was writing down here. And I think we could do more on that as health professionals, to make the case for increased support and investment in prescription and administration and prescription across the health professions. So that would be, I agreed with all of the others, but to try and add something else as well, Catherine, I'd throw that one into the pot.
Well, I love it. It's like a real call to arms across the professions, and we've had the viewpoints from our other colleagues from different groups, so to speak, and I'm not calling them special, even though everyone is special, but I think that really helps us feel mobilized, Howard, as we move into 2023. I'm going to wrap up here and say there's a lot of cross-cutting themes here. The final take-home messages said it all. Use every opportunity, using Howard's point, from every professional encounter with patients and the public to be able to explain and educate. Take a humble approach. Seek to understand where hesitancy of any type may exist. On a wider strategic area, let's think about breaking down barriers between involvement of pregnant women and children in trials, but maybe extend that more widely. Maybe there's a piece of work for us to do on that. Maybe let's think about every encounter we might have with a patient with respiratory problems, even before they have been diagnosed, as Sian mentions, and think about all the prevention we may do along the way. Not view aging as a homogenous special group, but view it as a continuum. And of course, we've got the issues that Irina very neatly put together about diabetes and perhaps needing a slightly different approach. So again, the NCDs don't have a cookie cutter approach. So in summary, for my team, we need to work with all the other professions to mobilize, think about how we might engage all of these special groups in different ways, but also in a cohesive way. Consider those specialist groups not as homogenous, but as having varied needs. They're all on a population spectrum as well. And also this life course immunization might be adapted to the life course medicines use, medicines trials, life course interactions, and advice and education. That has been an amazing event. I do apologize for the couple of tech hiccups that we had, but they're the only hiccups that we've had today. I cannot thank the panel enough for their time. I know how busy it is, and as we race towards the end of the year, the days seem to get shorter and shorter, not just in terms of light, but also in terms of the hours available to us. So we thank you so much. Particular thanks to our interpreter today, to the FIP team for their support with subtitles, and for Ruben and Gonzo for their amazing stewardship of this work. Having so many colleagues supporting and backing FIP at every turn makes us very, very grateful and feel like we're part of a really important set of work, not just here, but in our NCDs and in our prevention agendas more widely. Have a great day. Any more events, please don't hesitate to find us on our website, which is events.fit.org. You'll find all of the events from the past, but also we'll keep you posted for the future. A huge thank you to Howard, Pat, Jane, Sian and Irina. I know she's left us, but thanks a million, colleagues. Very, very grateful. Take care.
Thank you.